Hi, everybody, and welcome to this session. The focus of our panel session in the Medical and Health Theatre today is the underserved. So we're here to discuss groups that have been left behind in the global pandemic, what we know about their health and how we can better serve and support them. My name is Helen, and I'm a member of the Medical and Health Programming Board at the World Humanitarian Forum. And we have three great speakers with a wealth of experience and expertise among them who will be speaking with you today. I'd like to encourage the audience to think about questions while they're speaking and enter them into the chat so that we can make sure that your thoughts are heard and you're included as well. So let's get started. I thought that I would ask Dr. Sarash if she could introduce herself and the scope of her work.
Thank you so much. I am Davinder Sarosh. I'm based out of Karachi and serve as the country director for Pathfinder International. And, during the pandemic, we were implementing a large project focused on post-pregnancy family planning in Pakistan, which was supported by the Gates Foundation, in addition to an accelerated family planning project, And when the COVID-19 set in Pakistan, we were able to observe, the setbacks in the footfall to the service delivery points, as well as, the responses that were provided by the government and the private health systems. So I would be talking a little bit about that based on the needs and how we cater to different groups of people. Thank you.
Thank you, Tabinda. We're looking forward to hearing about that. And Esther, can I ask you to introduce yourself and your organization and work?
Okay, so I'm Esther Lehmann, and I'm working with World Vision. I'm based out of Senegal, and World Vision works in close to 100 countries. Many of them are what you would find on the fragile context maps of the world. And so who speaks fragility speaks underserved just by the nature of what the situation is. World Vision focuses on child well-being, and while COVID is not necessarily thought of being something that relates to children, there's growing awareness of something that we have experienced right from the beginning, that there's a lot of impact, side effects of COVID, not medical ones, but economic, social, etc., that deal with children. And so across the countries that we've been working in, close of all of our countries that we are working, we have seen firsthand the impact of COVID on children, especially the vulnerable women. For sure, they're always part of that package. And so that's our daily living, both from the economic impact, but also medical, social, protection aspects, etc.
Thank you, Esther. So I'm going to take the liberty of introducing our third panelist, and you won't see him on the video at the moment. His name is Dr. Robert Blum, and he has recorded his presentation for us today. Dr. Blum is a professor in the Department of Population, Family, and Reproductive Health at the Bloomberg School of Public Health at Johns Hopkins, and he is principal investigator of the Global Early Adolescent Study. So he will be speaking to that topic in his presentation. And I'd like to ask the World Humanitarian Forum team if they could please start Dr. Blum's presentation, and then we will come back to the other panelists afterwards. Thank you.
I'm Bob Blum, and it's a pleasure for me to be here at the World Humanitarian Forum to be able to share with you some of the work we have been doing with young adolescents, 10 to 14 years of age, around the world in low, middle, and higher income countries, exploring the impacts that COVID has on them and their families. I'd like to share my screen because I'll be presenting some of the data This work has been supported by the Young Health Program of AstraZeneca, and we couldn't be more pleased to be able to share with you some of these data for the first time today. So the study that we are in the process of doing explores how young adolescents experience preventive health practices, education disruptions, the impacts on physical and mental health and their well-being as a consequence of COVID-19, and the precautions that have been taken around the world. We have used a mixed method design with both qualitative and quantitative components. Here, I'll be sharing the results from 5 countries: China, Indonesia, where we worked in 2 sites, Kinshasa in the Democratic Republic of the Congo, Blantyre in Malawi, and in Flanders, Ghent and Antwerp in Belgium. As you can see, the sample size ranged from just under 400 to over 600 in both Shanghai and Indonesia. First, I'd like to touch on some of the COVID-related attitudes, knowledge, and practices. What we see in this slide is that there are significant levels of concern that young people express across sites. These scores were developed from 4 questions. 1, thinking about COVID-19 makes me feel threatened, concerned, scared, or anxious. 2, I'm worried that I or people I love will get sick from COVID. I'm stressed around other people because I worry about catching COVID-19. And I have avoided going out of the house or being near other people because I'm afraid of catching COVID. And what we see is that concerns are lowest in both Shanghai and in Belgium. However, they still are quite high. And in other countries, they are extremely high, both for boys and girls, though we do see girls having greater concerns, or at least expressing greater concerns than boys. Here we looked at both knowledge and preventive health practices across the various sites in the countries where we have been working. What we see is that in Belgium and in China, young people have nearly total knowledge and awareness. This is based on 7 questions we asked about preventive knowledge. Lower in Indonesia, DRC, and Blantyre, but we see something very interesting. Look at Indonesia. We see Denpasar and Samarang, the 2 sites in Indonesia. Knowledge is lowest. However, practice is highest, which does suggest that knowledge and practice do not always parallel each other. Let's look quickly at the economic, education, and social impacts. Here we see substantial impacts in all of our sites. Anywhere from 1/4 to 2/3 of young people report impacts of job loss or income loss on their families as a result of COVID. And clearly, the impacts are greatest in sub-Saharan Africa, in both Kinshasa and in Malawi. And we see in Malawi, 2/3 of girls report the substantial impacts of economic loss on their families. This also translates to food insecurity, which we see equally high in these countries. Another concern that young people have is academic and grade completion, with nearly 50% or more young people in all sites reporting significant concerns about completing the grade that they're in. We also asked what impact COVID has had on their education plans. And here we see some things that are extremely concerning. So look, for example, in sub-Saharan Africa. Nearly half of all boys in Kinshasa, and these studies have been done in the poorest sections of each of these communities. Nearly half say that COVID will have a detrimental effect on their completing school. More than 1 in 3 boys in Blantyre, in Malawi, say the same thing. What we also see is that girls are more likely to say they will complete more school than they thought they would complete before COVID. Now, one of the trends we're seeing around the world is that while in a number of areas of the world, girls are less likely to enter school than are boys, they are also more likely to stay and complete school than boys. And COVID may increase that gender gap that we are seeing. Some of the qualitative comments that we've heard, most adolescents believe both the quality of instruction and their own performance declined. Girl from Samarang, Indonesia said most challenging thing is the laziness and boredom from being at home, like feeling too lazy to read the material. A boy in Belgium said, I'm used to working hands-on. Basically, when I had to just type and send in my work, I didn't find it helpful at all. On the other hand, some adolescents also appreciated the increased flexibility of remote learning. A boy from Shanghai, China said you could go online at home, and after the online class is over, you could play and sleep longer every day. Well, in Indonesia and in China, there is very high penetration of internet, much more complicated in Malawi and in the DRC. A girl from Belgium said, I thought it was really cool that I could arrange my own day and take breaks whenever I wanted. So some advantages and some risks to this. Let's look at health and mental health. So overall, we see that in a number of our sites, Shanghai and in Samarang, Indonesia, adolescents report improvements of their health. And this may be a function of being able to sleep longer and have less school-related stressors than during the regular school year. We see slight declines in some of our other sites. But overall, we don't see major changes one way or another in terms of health. We do, however, see some major changes in terms of adversities experienced and then mental health. So we asked 3 questions about adversity in the past week to really try to understand what has increased, if anything. Verbal abuse within the family, emotional neglect, and witnessing physical violence at home with the 3 questions. Everywhere, young people reported an increase in adversities as a result of COVID. Look at Malawi. 70% of girls, 67% of boys report one or more of these adverse experiences increasing over the past week. Belgium, we also see very high reports, as we do in Indonesia, in Kinshasa. 47% of young people in Belgium and 70% in Malawi report experiencing at least one of these adversities as a consequence of COVID. We looked at anxiety using the GAD-7, the General Anxiety Disorder Scale, and what we see is that anxiety among adolescents from all sites is very high, with the highest prevalence in Antwerp and Ghent, in Flanders in Belgium. Just take a look at this. 70% of girls there report high anxiety levels, but we see that across the board. For girls in Shanghai, 41%, a third of girls in Denpasar and Bali, and 40% in Samarang. So anxiety is extremely high and appears generally to be higher for girls than boys. We also looked at perceived stress among adolescents in all of these sites. And these are young adolescents, 10 to 14 years of age. And we see high levels, these are moderate stress measures for boys and girls in every single site. Everywhere, at least half of all respondents report at least moderate amounts of stress. And girls tend to report more stress than boys everywhere. I was very unmotivated, and sometimes I got like mental breakdowns all of a sudden, and I thought it was really bad, one boy in Belgium said. There was no more joy at home, a young boy from Kinshasa said. The house became boring. When the phone rang, we knew that there was a problem. I miss the school environment with interacting with my friends. I miss hanging out with them, a girl in Denpasar said. And a boy from Shanghai, I usually talk about my inner thoughts or feelings with one of my best friends every month, but after the outbreak, I haven't been able to have a chance to do that. So what we see is that there are significant consequences, profound economic consequences, lack of income, isolation from school, anxiety, are all consequences of COVID-19. We as a global community are at a critical juncture. We stand a risk of losing one whole generation of young people because of the stresses they experience, the income loss and insecurities that their families have had, and the education impacts. The question is, how do we, as a global community, respond to this crisis? Thank you very much, and thank you for the opportunity to present.
Hi, everyone. Hopefully you can hear us, and we're coming back on now after Dr. Blum's presentation. So he has some quite interesting data there to share. So now let's shift gears a little bit and talk about what we have learned from other crises and speak with some of our other panelists. I'm curious, Dr. Sarosh, if you could share some of your thoughts on the things that we've learned from other crises such as Ebola and SARS, and maybe also if you could speak to how we can create more protective environments for women and girls and consider their rights in the face of the pandemic.
Thank you so much, Helen, and I hope I'm audible to everybody. So, Pakistan confirmed its first case of COVID-19 on 26 February 2020, and within 6 weeks, the confirmed cases had surpassed 5,000. And many of us who were involved in ongoing development and systems strengthening projects had to shift gears, to respond to the situation. Multiple explorations that were done in the field, of which we were a part of also, and some of them we led. We realized that one of the most marginalized groups, for this particular situation were the women and girls. Pakistan being a society which is heavily patriarchal, women and girls already face issues of mobility. And the health care providers started reporting a significant decline in institutional deliveries during the lockdown, which underscores the urgent need, for trained community midwives and trained community health providers. Also, the lockdown restrictions made it very difficult for women to access protective services in times of gender-based violence or domestic violence. We already knew from the Ebola crisis that domestic violence is something, and gender-based violence something, which goes up, during pandemics and lockdowns and situations where women face, a space where they do not have much mobility, and they're constantly cooped up within close family members, who can actually inflict violence on them. So the restrictions made it even harder for women to access the protective services like shelter homes and like the gender-based violence response services. In addition to that, many of the programs that were starting, they use the digital technology, and digital technology is something which is, which was more deemed more accessible. But when it comes to women and girls, in a society like ours, access to digital space is not uniform. Many girls don't even have a smartphone. And even when they're able to access the digital platforms, their safety and their privacy on the digital platforms is often violated. So that was another issue when it comes to providing SRH information, to women. In addition, we saw that the cost of services at the private facilities had gone up. So for example, cost of a post-abortion care service and the cost of an MVA tool, MVA kit, or had gone up. At the same time, in general, we were experiencing a diminishing supply chain of commodities, and these commodities included commodities for family planning, for post-abortion care, and essential medicines like misoprostol used for postpartum hemorrhage also went down. Their availability went down. So obviously no one had a manual, at that time on how to respond to the situation. Adaptability, flexibility, and responsiveness were our initial guiding principles. So one of the few risk areas that Pathfinder was able to identify very early on was the dearth of PPE, within the public health and the private health systems. The rising stigma of COVID-19, because in the initial days it was, we did not know much about COVID-19. There was a lot of stigma for the providers, and the providers themselves also had that stigma towards the clients. The health systems were strained, and SRH services took a back seat, because finances were diverted more towards the immediate COVID-19 response, providing the PPE, providing safety equipment. Then there was a cessation of community-based interpersonal communication through community health workers. They were not able to visit the households the way they used to visit. They were not able to arrange community support groups, and this actually had a great effect on women and girls. However, the good thing is that policy frameworks were developed very early on. So as early as March, the government of Pakistan at the provincial and the federal level, in consultation with civil society, had developed COVID-19 response mechanisms that included SRH and that included considerations, around gender. Our lessons learned, or our main, the thrust of our intervention was, number one, to ensure a conducive policy framework for COVID-19, to maintain the continuity of service delivery by bringing services closer to women, through the community midwives, through the community-based referral networks, which included young people who started using digital platforms like WhatsApp to refer girls and women to the nearest facility that was open and that had the right, equipment and that could respond to their needs. In addition to that, we operationalized a multi-level, multi-channel communication campaign, and this meant utilizing all the channels that were available to us, that could reach the women and girls in their houses. So cable TV networks, advertising on that, SMS campaigns through mobile phones, mosque announcements, vehicle mobile announcements, for example, rickshaws and chinchis announcing messages around what services were available in their neighborhoods, in their communities that they could access. In addition, we also used the platform of radio and television and standardized the messages after pre-testing, understanding the community's, fears and apprehensions about COVID-19, and integrating the salience of COVID-19 itself within family planning messages. So why was it important to take an approach that would ensure the safety of the family or the safety of an individual, and that included postpartum family planning, as well as SRH services, as well as services for referrals for gender-based violence with COVID-19 messaging. So if I have some time, I can quickly go through, go through some of the details. As the providers that we were working with more than 1,500 providers. These were community midwives and as well as women medical officers. We initiated a digital mentorship supervision plan with them, in which we actually connected with each provider on a digital platform after a digital training on how they could continue their services and the skills that they had newly acquired, for example, insertion of an IUCD, right? How they could do that at the service delivery point. If they had any troubleshooting questions, they could reach back to their mentor. And in order to kind of plug in sustainability considerations, we tried to develop master trainers for the government themselves. So this is something that the government could do themselves, even when the project was not present. In addition to that, we also developed customized virtual training modules on COVID-19, followed by gender-based violence modules for the providers to help them serve as a first responder for gender-based violence. In addition to that, in order to fight the stigma for COVID-19, we used a technique that we had been using for addressing provider bias for SRH services. And this included human-centered design approaches to connect with the providers, to motivate them to provide services, and to also, I guess, to have a sense of solidarity among themselves as well. They are not in it alone because they were not meeting each other and they were working in different basic health units on their own. The trainings were also for the first time not happening in a group setting, but on an individual setting. So we were able to connect with them, and this was a virtual platform that was also later used by the government for the community health workers. In addition, what we also tried to do was to recruit champions for this cause. And this included celebrities, whose faces were on the televisions, especially when you were at home. Television was one thing people were watching a lot of, and so was social media. So to develop public service messages that ran on television, local radio channels, that was very important. And we were able to kind of assess the impact of these interventions through the service delivery statistics, and very soon, in fact 3 months after we had initiated the response, the access data to the services for SRH had reached at par with the pre-COVID statistics, which showed that the women and girls, their SRH needs had not ceased to exist. So I can hold myself here, and we can come back to, and you can always call me back in for your next question.
Thank you, Tabinda, and just a quick hello to Dr. Blum, who has joined us. I would now like to move over to Esther and ask Esther if you can perhaps speak to the challenges around reaching children in remote and dangerous places, and also the role of the faith-based communities in humanitarian relief and considering the COVID situation currently. Thank you.
Thank you, Helen. A lot of what I will say mixes well with what Professor Blum and Dr. Sarosh already said. We are in many countries that have very poor infrastructure, both social infrastructure, but also even to reach them. And so one of the ways we work is working with local actors. I mean, most of the humanitarian actors do that. And mobilizing them is really one of the keys that we've seen in order to react to pandemics, but like any emergency situation anyhow. So our presence in over 100 countries, many of them are fragile contexts, being there on the ground, having established connections, having built trust over the years is an amazing asset. And having a lot of volunteers who are engaged with working with children and their families helps. Now, as we're a Christian organization in World Vision, we work with faith partners, even not only Christian partners. We work in good transparency and respect, and understand that in our world today, over 80% connect themselves, define themselves as belonging to a faith. And so coming from that perspective, there's often a lot of understanding and commonality of how important this is for informing of who we understand we are, but also how we cope with situations arising in our lives. What we also understood is, we mainly learned that through Ebola response, is the amazing voice that faith leaders have in changing or influencing behavior. So we learned during Ebola that as soon as imams and pastors came up and say, for burial of deceased, this is how we do it in a way to protect ourselves, the tide changed. As long as they had not spoken up, people were thinking they need to show their love and their faith obedience to maintain traditional behaviors which expose them to danger. And so we immediately used that to re-articulate the networks that we had already in place from the Ebola prevention and responses, to now adapt that to COVID and also activate the faith networks that we had across our countries. So they were very smart. They used their WhatsApp chat groups, and they used digital medias before we even came to it. And so we learned from them on how to adapt, how to check messages, how to bring the correct information to them. And that has been an amazing asset. So one, to make sure they have the right information, and then to encourage those faith leaders, pastors, imams, priests, to use their influence to care for people, to help those who are not sure about what to think about. Should I do that or should I not do that? Should I accept vaccines? So we adapted the information that we had and are now using digital tools, and those volunteers are really out there. What they also do is not only talking about medical aspects, like should I take vaccines, or is that a real sickness, or is that just a political thing that they are trying to put on us, etc. But also to prevent some of those effects that Professor Blum and Tabinda have talked about on children and vulnerable people in general. You know, coping with economic stresses, coping with school closures. There are a lot of coping mechanisms. Some are very good and some are very detrimental. So if you send the children away to other families that might feed them better because you can't feed them, they can be exposed to abuse. Or you might opt to marrying them off to somebody who has some money to feed your girl. So if you do that, it's a coping mechanism. That's okay for now, but it has tremendous negative effects. And then getting the faith communities involved in those discussions, reflections, and helping them to counsel parents of what other coping mechanisms could they use to avoid those negative ones. But then also strengthen the community solidarity. Like if there are no schools, many children are both exposed to what we have heard of domestic violence. They witness it, they are themselves exposed to it. Their safe space has been, their routine has been disturbed. They don't have their peers that they can just vent what they're experiencing. All of that is a huge stress. But also even physically, how many children live, the only regular meal they get is the school meal? So the school feeding, if those are closed, I mean, the effects are physical, mental, psychological. And then the role of faith leaders, equipping them to understand that, counsel people, help them strengthen that social network that is a positive asset in responding to such a pandemic, and minimizing some of those negative coping mechanisms, or identifying parents that might need help because they just simply can't cope with the stress, etc. We also help like giving first psychological aid to teaching that to pastors and other faith leaders, because they are often the ones that are called on when there's bereavement, when there's other heaviness on people. The spiritual leaders are just the persons of trust. And so if they're not equipped in how to recognize and deal with, at least to some level, some of the psychological stress, the trauma, they will be less able to really do the good work that they're doing. And so what we're doing is really mobilize, strengthen those networks that are out there with faith leaders, and make sure they have the right information, the right tools, and that they're acknowledged also. One of the things I think we have seen is that the faith leaders or the faith communities, or the aspect of faith for our mindsets, for how we make decisions, has not been articulated strongly in a lot of the discussions. Like, for example, would you accept vaccines or not? Is if we have done barrier analysis, and we had countries that have said in 100%, if my faith leader says yes to it, I will say yes to it. If they are in doubt, I will not do it. Or if they have not heard, even if the message comes from health personnel, even humanitarian personnel, go and do certain things or don't do those things anymore. They don't trust us necessarily. They trust us to a certain level, but in order to change behavior, they need to have a trusted person from inside their community. So the community leader, faith leader, who need to say those very same things. They're not paid to say what we are saying. Health personnel, humanitarian people, we are paid to pass on certain messages. Those people are trusted. They're one of theirs. And so using them, empowering them, including them in some of the discussions and processes, I think both internationally and locally, we have failed to use them as an asset for protecting vulnerable people, mainly for us children, but even beyond that.
Thank you so much, Esther. That was so interesting, and I definitely learned a few things myself. What I'd like to ask actually is now ask Dr. Blum a question, just relating to your presentation. You ended with a statement about how we are potentially losing a generation to COVID for so many reasons. I wonder if you could give some thought to, like, how can we then, build back better is a phrase that we hear a lot. What are some of the things from the work that you're seeing that we could consider moving forward that might help address that potential loss?
Well, I think that we are clearly seeing young people who have lost 1 to 2 years of their education.
Yes.
And at that age, to lose that amount of education is almost impossible to regain. So from a humanitarian perspective, the needs are profound. You have populations who already live in extreme poverty going further and further into poverty. And the hope of getting out of that poverty really lies with education that creates new opportunities. So from an investment perspective, when difficult choices are needed to be made, and I resonate strongly with what you just said, Esther, that social networks have incredible power to help sustain populations in this extreme time. But those social networks need the support of an education system and investment in schools, investment in getting young people back to school, investment in hope that education still matters. I mean, our data suggests that there are very significant numbers of young people who do not believe now that education is going to matter. And this is even more true for boys than it is for girls. And I think that it is critical that we invest our resources in strengthening the education system and reaching out to young people and their families, that during these times, the return to school is even more important. And much like everything you said, Esther, the opportunity for engaging the faith community in this process is absolutely critical. First of all, in many places, the faith community are the educators. They are just the advocates for educators. They are the educators. And so engaging them, but even where they are not, where there is a more robust education system, they have the powerful voice of getting young people back to school by influencing parents. I'll stop at this point.
Thank you so much, Dr. Blum. I think it's really interesting to note the role of social networks, but also the role of government policy. And I wondered perhaps, Tavinda, if you could speak a little bit more to that element, which you did reference in your remarks. And I agree is an important support to kind of formalize some of these new approaches. So could you share a little more about that element?
Sure. So one of the things, oh, sorry.
That's okay.
Sabina, my apologies.
No worries. Thank you so much. So you see, I think the key lesson learned for an organization like Pathfinder, which mainly works with the government's health systems in the country, was that institutional preparedness is essential. Institutional preparedness is not something that we focus on even when times of crisis are not there. And hence, the health systems are always vulnerable to getting overwhelmed and also to prove inadequate, to meet the needs of the people. Nobody was expecting the pandemic, but the pandemic itself, forced the public health systems and the private health systems to make a lot of innovations. We have evidence about the important role of frontline providers already and community-based cadres, which actually interact with all these social networks that Esther and Robert were just talking about, right? These are the bridges between the communities and the providers and the service delivery points. So they need to be strengthened because referrals won't be able to be redeemed, in a situation where these bridges are not present. So a holistic institutional response that has invested in the safety and preparedness of the cadres themselves is more likely to provide essential services at the community level. And it will play a role in avoiding the overwhelming of the health systems. COVID-19 heralded an era for a new normal here in the public sector. The government upped its appetite for digital technology for internal processes like data collection, data analysis, training their employees, connecting with the employees. Reporting also was something that was being done on WhatsApp. Often the number of clients that a service provider was meeting was reported back in terms through WhatsApp. So the government started exploring innovation. The government started exploring digital technologies for service delivery. They are now also thinking about institutionalizing telehealth because COVID-19 at the moment is not going anywhere from Pakistan. So the lessons, I think, have been many, but I think fresh avenues have also opened up for us to reach the women and girls, which were not very obvious before. We always thought the best way to reach a woman and girl is through a community health worker. And while that still stands true, the youth networks that mobilized themselves in the districts following COVID-19 and that sense of responsibility within a community that was also awakened through COVID, using different kind of technologies to not only connect with each other but also to make referrals. This gives us an opportunity to catalyze the reproductive agency and growth potential for women and girls. This also paves way to involve men, in SRHR services, because through digital platforms, it's considered more safe. There's no one-on-one contact in a society where women and men are usually, they do not intermingle too much. These platforms are providing opportunities to involve men as supporters, as positive decision makers for the families, and also adopters of family planning. In addition, the pandemic also, I think, at a very mass and collective level, it invoked the empathy and influence of the local actors and champions, who wanted to make a positive difference, who wanted to be heard. So I think these were the lessons learned when it comes to public health systems strengthening.
Thanks. And Dr. Blum, I think you had a comment that perhaps if you have anything to add or build on what Tabinda has said.
What I was going to just very briefly comment on is that from some of the data that we are seeing, where there are social support programs that governments have in place, young people and their families are weathering this pandemic better than in countries where there hasn't been. And we see this clearly, for example, in a country like Chile, where there had been a social support program for children and youth that was in place long before the pandemic and long before the current government. And those young people and it isn't evenly distributed across the country. Those young people where there is this type of social support program have less food insecurity than their friends and peers, and are experiencing much less of this steep decline into profound poverty.
Thank you. Esther, I wonder, there were a number of sort of what I would consider like ingredients for a good response that you were referencing in your work, and I wondered if you could kind of talk about them a little bit more, like what are the things that you think are really critical to include in when you're trying to improve support or help more vulnerable populations during an emergency such as this one, just to kind of put a fine point on it for the audience?
Well, I think there's many lessons we can learn. One is that health is not a standalone problem. Okay, any health pandemic is a multi-layer sector issue. Anything, it has to do with infrastructure, it has to do with money, investment, it has to do with political will, it has to do with attitudes. So it's multi-layered, and the population you reach, even though there might be one specifically vulnerable group, it's not a standalone neither. It's linked, and they carry others, and they're carried by others. So we need to think in a more holistic way, and not just a clinical way. And I think that, for me, is one of the main wake-up calls in the global side, that we started out by a very clinical focus on it, and we sometimes still have it. Like when we talk about vaccines, we still have a very clinical viewpoint, instead of thinking more holistic. Who are the influences? Who are the whole network, the surroundings that are part of it? So that's one. So I think going back from the clinical thinking to more holistic approach in both prevention, response, and building back up again is a critical thing. If we don't get that one right, we will miss it. Then the other thing is participation. I think one of the things that we are not getting right is thinking that medical is all about medical people. It's about the users on the other side as well. Who are those receiving it? And if they're not involved in the solution development, I'm not talking about the laboratories, they don't all need to sit in there, but like when we talk about vaccine rollout, if we don't involve all those nations that have a poor infrastructure, we develop vaccines that need -50 degrees cold chains, and they barely manage to have a fridge going in those countries. So we need to have that right from the beginning. If we participate in that and make that more inclusive, we have a much more realistic chance of getting the solution out fast. So I think the voices of women, the voices of children, the voices of displaced people, be that in fragile contexts, be that in our more rich countries, the homeless, the not registered people, those who don't have their paperwork there, we didn't include them in our thinking through, and they are now the big risk groups. And we might think it's all set because everybody's vaccinated. Well, we know from other sicknesses that those who are not registered with their papers, they might not have received the vaccines, and they can become a risk group. And so I think, so in participation of those critical groups, which don't jump into your eyes immediately when you face a problem like a pandemic, is the third part that I would suggest. I see that we are nearly done, so I don't know whether I have more time or whether we should close here.
Well, no, Esther. You're right. We have 5 minutes, but there is a question that's come from the audience that I'll put out to the panel, and we're going to push it to the end of the session. Get every minute in. So the question is, what do we need to start with to scale up supports for underserved populations? Is it policy changes, response, prevention, research? So I'm going to put it to all three of you, and whoever speaks first can start.
Well, one of the things that I would like to suggest is, while policy and research is all important, the social accountability networks that need to be in place and need to be strengthened to hold all the actors accountable for those things need to be part of the policy. So only just making policies without having the implementation parts in it will not work. And I think in the underserved population, those social accountability mechanisms are not necessarily strong. If not, they wouldn't be already underserved. And so keeping that social accountability part inside of the policy work will be an important thing.
Thank you. Bob?
I would say that one starting point is the critical need to see populations who live in extreme poverty as us, not them. And it is a mindset. It is to not believe that we are doing anybody charity. It is to believe that we are doing and treating people as equals. And then our policies flow from that. If our policies are based on a notion of charity, it is that we have and we need to help poor people. We don't need to help them. We need to put into place programs that acknowledge their humanity and that provide them the resources to be able to sustain themselves. Because that's what everyone wants. They just want a fair chance. So the policies need to really reflect our notion of what a community is. And a community includes the homeless. Our community includes those who are HIV positive. Our community includes the ethnic minorities in our country as part of us in our community. And then build the policies that reinforce that.
Thank you, Bob. Tabinda, do you have any comments as we head into our last couple of minutes?
Yeah, thank you so much. I don't want to repeat what Esther and Dr. Blum have already said around community-based accountability. Communities are an essential part of the health systems, you know, and unfortunately we don't see a lot of community feedback loops and accountability systems. So that is one, but one area where I really wanted to emphasize was that where we could start from is actually data, you know. I mean, what we often find is that we do not find enough data within the health systems that could help us design the right response, you know. So for example, one of the things that Pathfinder was able to do during COVID-19 was to upgrade the DHIS in Pakistan to include indicators around wealth quintile, to include indicators around, you know, not just service uptake, but the, you know, but the cessation of services or switching of methods, you know. And if this kind of data is not available, it will be very hard to do targeted programming for the communities. And the last point that I wanted to make, which is very important, and it kind of speaks to what Dr. Blum also said, is that integration of programs, you know. So for example, how can a family planning program also respond to survivors of gender-based violence? You know, that kind of multi-sectoral or intersectoral lens needs to come in the programming. Departments need to be speaking to each other. Thank you.
Thank you, and thank you so much to all our panelists. We are out of time. We really appreciate your participation and your expertise and your perspectives on how we can make sure that the underserved are not underserved, but are remembered and considered during this pandemic, and I think moving forward, more generally speaking. Thank you very much, everyone, and have a great day.
Thank you, Helen. Thank you.
Bye-bye.